Okay, so today we're going to be talking about post-operative nausea and vomiting. And post-operative nausea and vomiting is one of the most common causes of patient dissatisfaction after anesthesia. Post-operative nausea and vomiting can occur as a result of particular surgery, type of anesthesia used, medications administered, or the surrounding environment. However, most risk factors have been found to be patient-related. For example, is the patient of a female gender? Does the patient have a history of post-operative nausea and vomiting? A non-smoker status of young age? Use of more volatile anesthetics and post-operative opioids. Currently, in the perioperative stages of patient care, nurses are required to use a risk assessment tool for post-operative nausea and vomiting. This assessment includes questions such as, is the patient a female past puberty? If yes, is the patient premenopausal? Does the patient have a history of smoking, a history of motion sickness, a history of post-operative nausea and vomiting? And is the surgery planned to be performed laparoscopically? However, there are identified issues in current clinical practice, and this includes incomplete risk assessments before surgery, lack of documentation of IV fluid balance during the perioperative stages, the need for better use of combinational antiemetic therapy rather than repeating a medication previously administered, better management of post-operative environments, and a non-cohesive multidisciplinary team. I've also found through my research that there is no golden standard or standardized guideline on the management and prevention of post-operative nausea and vomiting. Each article provides different information and different opinions. This could cause confusion as to what is the best evidence-based practice. So why is there a gap in practice? Why are we not meeting the guidelines? It was found that pre-operative risk assessments were most incomplete when patients did not attend an in-person pre-admission appointment. This means that the patient is not being provided the education and the pre-admin care that is required, leaving a gap in practice. It has also been found that during perioperative phases of care, there is a lack of documentation in fluid balance charts, which can be quite dangerous, particularly post-operatively with nausea and vomiting. We can go into areas of over or dehydration, which is always a risk. Recovery rooms are not providing a healing environment. This may include noise levels, light levels, etc. And poor documentation. Poor documentation leads to poor handovers and therefore a lack in continuity of care. So how do we improve practice while still reducing post-operative nausea and vomiting? We can do this through the implementation of management guidelines. It has been found that implementing such guidelines decreases the incidence of post-operative nausea and vomiting. In addition to implementing guidelines, the implementation of standardized computer-based automated reminders, it has been found that using a decision support system in conjunction with a risk assessment improved the compliance to the guidelines and reduced the incidence of post-operative nausea and vomiting in patients. This included higher risk patients. Hydration is been noted to be quite a big area, particularly in post-operative nausea and vomiting. It has been found that increasing fluids post-operatively without contraindications assists in post-operative nausea and vomiting. It has been found that higher doses of IV fluids, a rate of 30 mL per kilo, were associated with less emesis rather than the standard 10 mL per kilo. There was also no difference in efficacy between crystalloids and colloids when similar volumes were used in surgeries associated with minimal fluid shifts. Dehydration as well as overhydration is an area that is particularly significant to post-operative care. And without effective and detailed note-taking on fluid balance, the patient may have impaired post-operative outcomes, and this can include renal impairment, increased infections, complications such as pulmonary edema, cardiac complications. So by eliminating the factor of dehydration and providing documented fluid balance, we are able to monitor how much the patient needs, how much the patient has on board, and eliminate this factor altogether. Another big area is antiemetics. Combinational therapy for postoperative nausea and vomiting prophylaxis is preferable to using a single drug alone, demonstrating that the effects of antiemetics acting on different receptors are additive. Adults at moderate risk for postoperative nausea and vomiting should receive combinational therapy with drugs from different classes, as the efficacy is optimized when combination of drugs with different mechanisms of action are administered. Through my research, it has been found that ondansetron with either droperidol or dexamethasone are most widely studied and most widely preferred. Other strategies that we can implement include recovery environment. This includes controlling excessive noise and bright lights in recovery and wards. This has been found to decrease patient agitation and thus the need for analgesia, therefore decreasing postoperative nausea and vomiting. In addition, fluid balance charts. Ensuring fluid balance charts are appropriately documented during the perioperative phase by the anaesthetic nurse. This ensures that fluid levels are appropriately documented for postoperative phase of care and decreases the risk of dehydration.
Now we come to the end of the presentation for postoperative nausea and vomiting. Here are my references. To conclude, there are a lot of areas that do need some improvement in postoperative nausea and vomiting, but by implementing some strategies that I have investigated, we could alleviate such risks of postoperative nausea and vomiting.